Good afternoon. Welcome to the Wilson Center. Sexual and reproductive health is a human right. Yet almost everyone of reproductive age across the world, some 4.3 billion people, will lack at least one essential sexual or reproductive health service over the course of their reproductive years. The recently published report of the Guttmacher-Lancet Commission, Accelerate Progress, Sexual and Reproductive Health and Rights for All, puts forth a bold new agenda for changing that statistic. The comprehensive evidence and inclusive recommendations that this report lays out serve as a foundation for today's discussion of why achieving sexual and reproductive health relies on realizing sexual and reproductive rights. And copies of this report are outside of the auditorium. My name is Sarah Barnes, and I am the project director of the Maternal Health Initiative here at the Wilson Center. Today, we are happy to have partnered with Guttmacher Institute to bring you this valuable discussion of achieving sexual and reproductive health and rights for all. I would like to thank our panel of experts for their dedication in their work, their thoughtfulness around today's event, and their time and efforts to be with us here today. Please join me in welcoming our panel. I would also like to do a quick shout out to Lauren Carmen and Elena Galati at Guttmacher Institute, as well as Amanda King, Isabel Griffith, and Lizzie Wang here at MHI. Thank you for all your work making this event possible. Today's event is set up as an open discussion format, first between the panelists and our moderator, and then we'll open up to the audience for questions. For those of you who are watching online, please submit questions to @Wilson_MHI, and we will get those questions to our moderator. And please, for all of you here today, please join us for the reception immediately following this event. And now it is my pleasure to introduce our moderator for today, Jill Filipovic. Jill is a DC-based journalist, lawyer, and author. She is a contributing opinion writer for the New York Times, as well as a weekly columnist for CNN and the current New America Future of War Fellow. Jill is also the author of The H-Spot, The Feminist Pursuit of Happiness, which offers a new way to think about gender, politics, and happiness. Jill's and all of the speakers' full bios are outside of the room. Please welcome Jill, and thank you all for coming today.
Thanks, Sarah. And thank you, everyone, for being here. I'm very excited to moderate this panel of such intelligent, interesting folks who I think are going to really bring some life into this commission report that you hopefully all have in your hands. I'll quickly just introduce each of our panelists, and then I'll give them each a few minutes after our keynote speaker to tell you a little bit more about their work. So, first, we have Felicity Daly, who is the Global Research Program Coordinator at Outright Action International. Next to Felicity is Preston Mitchum, the Youth Rights and Health Coalition Co-Chair, Senior Legal and International Policy Analyst at Advocates for Youth. Then we have Patricia De Silva, who will also be giving our keynote. She is the Associate Director of IPPF's UN Liaison Office, and Dr. Mabel Bianco, the President and Founder the Foundation for Studies and Research on Women. Now I will invite up Patricia to give the keynote. Thank you.
How about my glasses? That would not be good. All right. Hi, everybody. Thank you for having me, and thank you for taking the time to be here with us today at this very important event for our community and for SRHR. So every year, about 200 million women in the developing region want to avoid pregnancies, but they cannot because contraception is not available to them. Around 45 million women receive poor quality or no antenatal care at all. Around the world, 25 million unsafe abortions take place. Nearly 2 million people become newly infected with the HIV virus at some point in their lives, 2 in 3 women will be victims of gender-based violence, and often at the hands of an intimate partner. And like Sarah just said, ultimately almost everyone of reproductive age, about 4.3 billion people, will not have access to at least one essential or reproductive health interventions over the course of their lives. I could go on, but this is just some of the evidence that demonstrates that we still have a lot of work to do if we want to ensure that everyone, no matter who they are and no matter where they are, have access to sexual and reproductive health and reproductive rights. The Guttmacher-Lancet launched its report in May 2018, Accelerate Progress, Sexual and Reproductive Health and Rights for All. The Commission puts forward a vision for sexual and reproductive health and reproductive rights for all, or as we call it, SRHR, that is affordable, attainable, and essential to the achievement of health for equitable development and human rights. At IPPF, we welcome the report. We welcome the report because we felt it is a critical addition to support the SRH community, not only in achieving the Sustainable Development Goals, but also to take us beyond them. The report, with the seal of scientific quality and scrutiny of the Guttmacher-Lancet Commission, presents a comprehensive, evidence-based, integrated vision of SRHR that recognizes that improving health depends on rights. For a long time, many policymakers have taken a narrow view of sexual and reproductive health and rights, a view that often will exclude the rights component, sometimes sexual rights, sometimes reproductive rights. However, this report makes it very clear that achieving human rights for all, as well as achieving the Sustainable Development Goals, will require a broader vision from countries. We have made considerable health gains since the world leaders reached a milestone agreement on universal access to sexual and reproductive health about 25 years ago at the International Conference on Population and Development in Cairo. However, full achievement of reproductive health, reproductive rights, sexual health, and sexual rights remains very hard and sometimes even impossible for a lot of people. These gaps in access to SRHR take an enormous toll. They take an enormous toll on individuals, on communities, and also on national economies around the world. Closing these gaps will require a holistic approach from all countries, an approach that includes the rights of individuals to make decisions about their bodies and their lives, free of stigma, free of discrimination, and free of coercion. The Commission recommends an essential package of sexual and reproductive health interventions that should be universally available. This package includes components that countries usually focus on, such as contraception, HIV prevention, maternal and newborn health. But just as importantly, maybe even more importantly, it also includes often neglected components of sexual and reproductive health, such as abortion, infertility treatment, LGBTQI-friendly services, youth-friendly services, comprehensive sexuality education, as well as the prevention, detection, and management of gender-based violence. The Commission, though, went further. They recommend concrete steps that countries should take to create an enabling environment for access to SRHR. For all, that includes actions such as legal reform, combating negative social and gender norms, incorporating sexual and reproductive health into universal health coverage, and more. As I said earlier, the Commission has put forward a vision that is affordable and attainable. And this is very important. It is a very important detail, particularly for developing countries. As you probably know, around the negotiation of the SDGs, negotiating the financing of the SDGs, aside from negotiating the SRHR components of the agenda, was probably one of the trickiest points for countries to find agreement. And as we know, you probably know here in DC, deciding who's going to pay for things can be a quite complicated conversation. So affordability, it is key to ensure political buy-in. In their approach, the Commission considers different levels of development and recognizes that while some countries will still require some level of official development assistance, ODA, some of them are in a position right now to start implementing some of these recommendations. In fact, in developing countries, an estimated $9 per person annually would cover the total cost of entirely meeting women's needs for modern contraception and providing health services recommended by the World Health Organization to all pregnant women. The Commission also recommends an integrated approach, as many sexual and reproductive health conditions are connected along the life cycle and overlap at specific stages, thus making the integrated approach services better positioned to address multiple needs and making it much more effective. The proposed integrated approach is not only affordable and can save lives, but can also save money, as it has the potential to reduce the cost of treating avoidable poor health outcomes. For example, investing in meeting the need for both contraceptive services and maternal and newborn health services would result in a net savings of $6.9 billion, billion with a B, in developing regions, compared with investing in maternal and newborn health care services alone. This is an important point, again, which is reflected and repeated across the SDGs. Spending money now, making corrective policy actions now, can save huge economic benefits for the future. Finally, the Commission makes a series of very practical recommendations, the prioritization and implementation of which will, of course, depend on each country's context, where they are on the ground, their realities, both in terms of infrastructure, policies, laws, human resources, etc., as well as how far they come on already implementing those services and achieving access to SRHR to all. I will not mention all of the recommendations. I do not want to put you to sleep. It's long, but do allow me to just touch upon a few of them. First, provide access to safe abortion services and liberalize abortion laws where necessary. You could guess that I was going to start with this one, right? It is the right of every woman to make decisions about their body. Yeah, I'm going to repeat that. It is the right of every woman to make decisions about their body, to decide freely on if, when, and how many children to have. Evidence shows that legal restrictions on abortion do not reduce the occurrence of abortions. Abortion rates are the same in countries where the procedure is prohibited as in countries where it is legally available. You know what would make a difference, though? Contraception. Let's get contraception into the hands of women that want to control their fertility, that want to plan their pregnancies. That will make a difference. Liberalization of the laws would, however, save women from the health dangers of unsafe abortions and considerably decrease countries' maternal mortality rates related to unsafe abortions. Second, support changes in laws, policies, and social norms and structures that enable all people to understand, protect, and fulfill their sexual and reproductive health and rights, and to respect the rights of others. Creating an enabling environment to implement these recommendations will be a key factor. Most places that are further behind in achieving SRHR for all will have to work really hard to create such a space. Changing laws is important, but changing long-standing negative gender and social norms is just as important. They go hand in hand. In a recent visit to a Caribbean country, I witnessed just how strong a role social norms play in maintaining the status quo, even when the government takes steps to make policy changes. We cannot stand idly by and expect our world to bend in a favorable trajectory. It is for us in this room and countless others who feel the same across the world to do the work to bend our futures and our societies toward empowerment, equality, and humanity. As advocates for rights and gender equality, we can play a very important role in moving the needle on this issue. Third, progressively expand access to an essential integrated package of sexual and reproductive health interventions, ensuring that the need of vulnerable and marginalized populations are addressed. If you haven't spent any time negotiating or in the rooms negotiating the SDGs, you know that leave no one behind is probably the most well-known motto of the SDGs. And there is a reason. We have indeed made progress in many areas of SRHR, but this progress is not felt by all. There are still great health disparities, specifically disparities related to SRHR. We must increase our efforts to reach those populations that are hardest to reach, that are marginalized, minorities, populations that are vulnerable or are living in vulnerable situations. These categories obviously will change depending on where you are and in the region of the world, but this is a reality. You can find those populations just about everywhere. We're talking about refugees. We're talking about migrants. We're talking about indigenous people. We're talking about people of African descent. We're talking about LGBTQI people, just to name a few. Fourth and last, address sexual and gender-based violence through policy changes, services, and prevention programs. At United Nations, at the high-level political forum, that is the space that we use to present progress on the implementation of the Sustainable Development Goals. Every single country that have came to report on Goal 5 is the gender goal, and this goal has a specific target that talks about gender-based violence. Every country that presented in that goal reported, regardless from where they were, from the global south, from north, developing country, reported that they are still struggling to end gender-based violence. Gender-based violence is truly an universal problem. We must continue to collect evidence. We must continue to scale up programs that work. We must continue to try to change social and gender norms that perpetuate those behaviors, as well as finding new approaches when those are needed. The reality is that this is not linear. Most of these recommendations intersect with each other, and in the end, ideally, countries will be able to implement them all by following the evidence-based, progressive, integrated approach that I just presented here. There is a reason why evidence-based is becoming a controversial phrase in some spaces. Evidence and facts are hard to ignore. They are hard to refute. It is much easier to polarize an issue and reduce debate to opposing ideologies if facts and evidence can be ignored. The Commission's approach, though, clearly shows that human rights and gender equality are not ideological totems, but in fact, they are tools and drivers which can have huge benefits for our societies if they are applied and if they are protected. Evidence shows that access to sexual and reproductive health services saves lives, promotes gender equality. Evidence shows that access to SRHR also increases productivity and household income, and has multi-generational benefits by improving children's health and improving children's well-being. This is why the Guttmacher-Lancet Commission could not come at a better time. It is indeed the call to action that is required, showing us that comprehensive sexual and reproductive health and rights must be ensured for all. The rights-based roadmap approach proposed by the Commission, it is the way to accelerate progress for SRHR. It is the way to achieve sustainable and equal development for all. And ladies and gentlemen, colleagues, the time is now. Thank you.
Thank you so much, Patricia. I'm going to go down the line and just let each of our panelists explain a little bit about who they are, why they're sitting up here talking to you today. So you all have their bios outside of the room, so I won't have them kind of bore you with every accomplishment they've ever done in their entire lives. But would love to hear a bit from each of you about your work, your relationship to the commission, and the general scope of what you'll be talking about today. And then I'll follow up with each of you individually with some questions. So we can start with Felicity.
Thank you so much, Jill, and thank you to the Wilson Center and to the Guttmacher Institute for inviting me to join you today. And I just want to add one of my affiliations, which is with the Australian Research Centre in Sex, Health and Society at La Trobe University in Melbourne, Australia. So Patricia outlined that there were a number of neglected communities that the commissioners framed. And I'm here to speak about one of those. So the new definition that the commissioners framed is groundbreaking in that it affirms that achieving sexual and reproductive health relies on realizing sexual and reproductive rights, which are based on the human rights of all individuals to freely decide on their own sexuality, including their sexual orientation and gender identity and expression, to choose their sexual partners, to have safe and pleasurable sexual experiences, and have access over their lifetimes to the information, resources, services, and support they need to achieve that state of health and rights without discrimination, coercion, exploitation, or violence. So the commissioners are particularly concerned, and so are we at Outright and the Australian Centre on Sex, Health and Society, on people with diverse sexual orientation, gender identity and expression, and sex characteristics, including people who define themselves as lesbian, gay, bisexual, trans, and intersex. These populations face serious barriers in many countries in accessing sexual reproductive health information and services. They are amongst those most marginal and vulnerable groups, and they're amongst those groups that should not be left behind in implementing the Sustainable Development Goals or achieving this SRHR agenda. Now, what are the barriers? Well, before I go into what they are, I will talk about what they're sort of based around. Stigma, discrimination, including amongst health workers, and violence, which are emboldened by state-sponsored homophobia and transphobia, which criminalize sexual practices used to police same-sex sexuality of men in 72 countries and women in 45 countries, and control gender expression through prohibition on gender nonconforming appearance and behavior, and the denial of gender recognition. The commissioners note that people's fear of disclosure of their sexuality or gender identity to their healthcare providers greatly inhibits their ability to receive the correct information and healthcare that they need. That means they can't access reproductive health commodities that they also need to protect themselves and their partners from risk, particularly when they're young people, which is something that Preston will talk about. So it's been really fantastic, and if you've got the report, I think this is the abridged version, but if in the Lancet publication itself, it's on page 2,670. It's I use this page all the time. It's so important that the commissioners have pointed out basically the top 10 SRH needs of LGBTI people. And some of them will sound very similar to the general population. And some of them are specific. So what are they? They're contraceptive counseling and services, reproductive health screenings, access to safer sex technologies, counseling for sexually transmitted infections, including obviously HIV, and risk prevention, STI treatment, including for HIV, pregnancy-related services, addressing intimate partner violence, tackling sexual violence, dealing with survivors of rape, or what some people call so-called corrective rape, which is to punish particularly women who are gender non-conforming, counseling on fertility options, family planning for LGBTI people, and the provision of hormone therapy for people in transitioning. So we really congratulate the Commission for ensuring that the specific SRHR needs and rights of LGBTI people have been highlighted in these important ways. Just to say a bit about, what needs to change in terms of the barriers. Outright and Archis outlined the same set of needs of SRHR people in this paper called Agenda 2030 for LGBTI Health and Wellbeing, which we launched at the 2017 UN High-Level Political Forum on Sustainable Development. We've got a really nice fact sheet on that, just a 2-pager, that's on our website. And that we recommended UN member states to do the following things. They need to repeal punitive laws, policies, and practices that criminalize consensual same-sex behavior among adults and the self-determination of gender identity. They need to legally prohibit the non-consensual medical procedures, including the genital mutilation of intersex infants, forced sterilization of trans people particularly, and forced anal examinations. We want them to collect the number of services that address the sexual and reproductive health needs of LGBTI people nationally. So don't leave us behind when you're delivering SRH services. Measure access to reproductive health commodities relevant to LGBTI people, which include condoms, lubricant, dental dams, latex gloves, finger cots. Document the inclusion of sexual orientation and gender identity issues in comprehensive sexuality education provided to young people and young adults. And importantly, what can we do first and foremost? Ensure that sexual and reproductive health care providers commit to non-discrimination and respect for the human rights as they provide SRHR services and information to the general public and to LGBTI people in particular. So I'll leave that there, and I'm sure we'll have a lot of crosstalk and intersectionality as we explore things further. Thank you.
Thank you. Preston. We'll applaud first and then Preston.
Yes, applause for all of that. Hi, everyone. Hi, everyone. All right, so I'm around young people a lot, so I really appreciate just energy and responses, and I do a lot of call and response. So to start this off, I would like everyone to repeat after me. Young people will save the world.
Young people will save the world.
All right, thank you so much for entertaining me. All right, so my name is Preston Mitchum, as Jill noted, and I am the Senior Legal and International Policy Analyst with Advocates for Youth. I'm also the co-chair of the Youth Health and Rights Coalition, or YHRC. To explain a little bit first about Advocates for Youth, Advocates for Youth is based in Washington, D.C. We're about 2.5 blocks down. And we champion policies and programs, both internationally and domestically, centered on young people's sexual and reproductive health and rights. We work in 5 issue areas. Some are abortion access, contraception, comprehensive sexuality education, HIV, and LGBTQ health equities. We worked all over the countries, but just kind of to level set, it's really important that folks know, because a lot of people think of Advocates as just a domestic-based organization. We do have an international department and an international LGBTQ department specifically. We worked in Burkina Faso, Kenya, Mexico, South Korea, South Africa, Chile, Uruguay, many others. I won't belabor that point. But the reason why I really love Advocates and what connects me both, and thank you so much both to the Wilson Center and Guttmacher Institute, what really connects us is we work with 130 young people in the United States specifically, and part of our 8 youth councils. In addition to that, we have an African Queer Youth Initiative, which are, based in Eastern and Southern Africa, of many young people who identify as queer, trans, and/or trans, doing work on really ensuring that young people have access to sexual and reproductive health and rights and access to healthcare services in Eastern and Southern Africa. Some of our 8 youth councils are, I like to call, really say they do the work, and they encourage us to really make sure that we're staying on top of the work. So some are ECHO, which is our newest youth council, engaging communities in HIV organizing. One of their biggest tasks forever, I shall say, is to really make sure HIV is decriminalized. all over the country and in many parts of the world, HIV is criminalized, which is really criminalizing a medical status, a medical condition, something that really folks have access to more information on. Science has changed, obviously, but unfortunately, laws have not caught up with science. And so because of that, these young people are really focused on making sure HIV is decriminalized. We have what's called our International Youth Leadership Council, which are college students in the Washington, D.C. area, and Maryland and Virginia, but they're really focused on being excited about U.S. foreign policy. So yes, there are 18 to 22-year-olds who are excited about U.S. foreign policy. I know it's contrary to popular belief, there are many. And I'll leave one with our 1 in 3 campaign, which is focusing on abortion destigmatization. And also one of our more popular ones is Know Your 9, which is a sexual assault prevention organization that's a youth council. Was separate and now it's a part of Advocates for Youth. So the reason why all of that is important is because it's really critical that young people and their voices are centered when it comes to SRHR. Many times young people's voices are not centered. They're not part of the conversation. They're not part of the table. And so when young people are not part of the table, what they do is flip over the table that's there and create their own. And many times that's really necessary, right? So if you're not a young person who is being centered in the conversations, what you really do is start to develop your own programs and pushing legislators and ministries to develop policies and practices where they are centered and their voices are heard. I also think it's really important to mention YHRC in this space, which is comprised of advocates and implementers, working with youth and youth adult allies and partners and ensuring that young people are centered being involved with sexual and reproductive health and rights. They work with key stakeholders on things like commodities, so insertive or internal condoms and external condoms. Sometimes we hear them called female condoms. I'll give a note about why things shouldn't be cis-centered, and that's cis-centered, making sure that trans folks and gender nonconforming and non-binary folks are also part of the conversation. Young people are included in all of those groups as well. Working to ensure that SRHR information and tools are included within that conversation. We've worked to develop the adolescent girl strategy, so we help to have a lot of conversations about that when it was a beautiful thing. I'll end that there. And so we really make sure to work with USAID and the former administrator, Gail Smith, on adolescent SRHR issues. I could continue about the wonderful work of young people, and I will, but because this particular question was focused on why we are here, I'll stop there, but excited to have a wonderful conversation where young people are centered and not just a seat of the table, but making sure that their voices are continuously heard.
Patricia.
Hi. Hi, and I mean, I just spoke for a long while, so I'll try to be short, so that to give out some of my colleagues a chance to talk as well. But in terms of work, so I work for the International Planned Parenthood, the federation. There's a few of us, and sometimes people get confused. And so we are the International Federation, and we have offices in about 147 countries, and we partner locally with local NGOs, and we support them in providing services at the local level. And so they provide the wealth of SRHR services that in any given country, depending on the policies, can include abortion. But most of the time, we work on cancer screenings, on STI preventions, on services for youth, on comprehensive sexuality education, and other programs. Myself specifically, my work is less programmatic and less on the field, although I do that as well on occasion, but my main focus is to advocate for SRHR at the United Nations and other international fora. And what I do is that I talk to those persons that are making those decisions on what will be included in these global documents, agreements that we are talking about here. And we discuss in terms of SRHR what it makes more sense, what it is the most needed, what it is the most urgent. But then it is a negotiation because it is 192 countries trying to find consensus and middle ground. So we have to do a little bit of a give and take in order to ensure that those priorities and those concerns are reflected in those agreements that are made both at the UN here in New York, but also in other regional
documents that are also negotiated. And I should say that generally speaking, we are able to get more progressive language in the regional documents rather than on the more global ones. And I think you can guess why, because it's just, it's just easier that way. So I'll stop here and I'll let Mabel.
Thank you.
Well,
We have to applaud for everyone or no one. Mabel.
okay, thank you. Well, first of all, I want to thank for this invitation. And it's very interesting that you have a voice from the south, really, very south, far away. And well, I'm a medical doctor, a master in public health and epidemiologist, but since the last 30 years, I'm an activist. I created the Fundación para Estudio e Investigación de la Mujer, that is an organization doing research, but specially oriented to women's issues and to the field mobilizing the women and the young women and young people about it. So we work a lot with the advocates for youth many years ago. Yeah. What is the problem and why when we created the foundation, we were a group of women feminist professionals working in the Ministry of Health after we recovered democracy and trying to mobilize and to be having sexual and reproductive health and rights in the country where we used to deny them. Meanwhile, no one understands this, but for many years, contraception was forbidden in Argentina. So we need to say that for us, with the recovery of democracy in 1983, was a work to recover sexual and reproductive rights, not only health services. So I work on that, and that's why I became an activist, because this requires to be mobilizing the people and making them realize why, and because we need this, because we have a high mortality, maternal mortality, we have a high early pregnancy, adolescents early pregnancies, and we have HIV, of course, and we have many of them, but we were not talking about sexuality. We were not having sexual and reproductive health, not family planning, as we say at this moment. And of course, we have no safe abortion. So these are the key points why we decided one of the priorities for our organizations will be to fight for those rights for the women and girls. So we started before Cairo, and we were preparing for Cairo. So for us, it was so important, Cairo. And in the region, I work with the Latin American and the Caribbean Women's Health Network, and we were fighting a lot for Cairo, and we were so happy that we could change and not interrupt the demographic goals and pass to the right goals. For us, this is the key issue in Cairo. So after this and before, in Argentina, we start mobilizing and requesting at the parliament to have a law for sexual and reproductive health. Why a law? Because if you have no law, the problem is that we start to mobilize from the government. When the next government comes, withdraw everything. So if you have a law, you ensure that. So we fight for the law, and we fight since 1992 till 2002, 10 years, but we were there, strong, waiting, and we have our law. And the law was not the best, but was the law, was important. And later on, we fight to expand the law to have surgical contraception included, because it was not in the first one, and to have comprehensive sexuality education. So 4 years later, in 2006, we have these two laws. So we have good laws, but the problem is how they are coming back to the people, and this is the great problem still we are having, fighting for that. But also, we have nothing changed, or very few changes on the issue of abortion, safe abortion. So we have divided ourselves how to continue fighting. We need to improve the implementation of the laws, but also we need to have new laws for abortion, to expand unsafe abortion. So this was how we managed there. And so we decided in 2006, most of the activists from the sexual and reproductive health, to create a campaign in which we say comprehensive sexuality education to avoid pregnancy when it's not decided, contraception to avoid abortion, and safe abortion to avoid death. So this is our key points. So we fight, but it was no easy. We make a lot of alliances. We find out, for us it's important to point it out, the problems, and not to put in the front the issue of the rights of the women to decide on their body, because this seems to be in our Catholic and New Evangelical important communities, growing. This seems to be not very useful for us, because it seems to be is something only for some young women. And this is not a problem of the young women, if of all the women, and of course, if for all the society. So we started to push and to make knowledgeable all the cases in which the women are dying due to the lack of sexual and reproductive health and the denying of an abortion, a safe abortion, because they are all together. They, first of all, they deny, and they have no access to contraception, and later on they deny the safe abortion. So they are dying. And with the increase in the rape, this is one of the problems. That's why we are having more and more young women, girls at 9, 10, 11 years, that they became pregnant. They couldn't have an abortion, a safe abortion. Meanwhile, the law permitted, but this is a problem of the habit and the customs and the issues of religious, that it was, and cultural, that it was not possible. That's why we fight so hard. And I think the important issue was that we were increasing the number of feminicides in the last 10 years and more in the last 5 years. So it was a great movement against feminicides. And this movement, we include in this the issue of abortion as a violence against women, because the 9 safe abortions is a violence. So it's not only sexual violence, but it's also later on the issue of abortion. So this was marvelous. In 2015, it was a great demonstration in all the big cities in Argentina for the first time, and with millions of men, women, children, elderly, everybody there, saying no more women needs to die. And in this, we added abortion there. So this was growing, and the last March 8th, 2018, it was such a big demonstration that the government, that was not, because we have a problem that all governments in Argentina, maybe very progressive, maybe not so much progressive, doesn't matter, they don't like to speak about sexuality and about sexual and reproductive health and about abortion, less and less. Meanwhile, the people needs that, and the people recognize, and this is not a political issue that they say is taking away votes. This is not true, but they are afraid. Okay, they don't want that. Okay, so this was such a big demonstration that the government says, well, the president itself says, well, maybe we could discuss, maybe they can discuss in the parliament. We have been working with the parliament since we recovered democracy in 1993. There were many projects there to enhance abortion, to become safe, and no one couldn't discuss because the executive, the majority, they say, no, this is not good. So for the first time, we have that opportunity. And we use the opportunity, I must say, and we have the mobilization of the young people, the youth and the adolescents. This was so impressive, so impressive. So we have in the secondary schools, the boys, the girls, fighting and saying, this is an injustice. Those poor women are dying. The girls are dying. This couldn't continue. So this is so the green scarf that we use. I didn't bring anyone, sorry, here. And we have this only. It became something that everybody was bringing, and the young people are still there. So we started the discussion in the parliament. In the representative chamber, we win, and we have a very good project, better than what we proposed initially. But it went to the Senate. In the Senate, this was not passed. This was not passed because they were more conservative, and, well, we think we need to have, it's different, because in the Senate we have 3 per province or state. So these 3 are different. They are not representing the amount of the people as it happens in the representative. So, and they have a great pressure from the church and so on. So this is why we didn't have the law, but we know we are going to have it. We are going to have it, and it's going to be very soon. Thank you.
Thank you. Thank you. So I have some questions for our panelists, but as we're all up here chatting, I hope that all of you in the audience and folks that are watching at home will be coming up with questions of your own. I'll open it up in a few minutes to let folks ask the panelists whatever you want. I would just ask that your question is actually a question and that it's something you actually want the answer to. Something you're genuinely curious about. So using that as a framework to consider the rest of our conversation. And to the panelists, we have a huge group here of informed, engaged, interested folks. So I'm going to ask each of you to keep your answers to the questions to like 1 to 2 minutes so we can cover the whole range of what people want to hear about, if you don't mind. And then we can dig in deeper, since I know there's a huge wealth of knowledge sitting up on this stage. So I want to circle it back to Felicity. And Felicity, you talked about what some of the barriers are to more expansive sexual and reproductive health and rights. Can you tell us a little bit about what has worked to decrease discriminatory barriers to service?
Well, I mean, I think what we've seen in some countries that have actually had law and policy change, we're having some breakdown in people being able to be a bit more forthright with their family, friends, and their healthcare providers. But I would say, there's still there's a majority of states that are unwilling to norm LGBTI inclusion at a diplomatic level and through access to basic services. So, I think there's still a very sort of heteronormative domain in sexual reproductive health service provision, and people's inability to see a client for who they are when they're asked to provide quality relevant care in a non-discriminatory manner. One of the things that I think we need is a much more robust evidence base. We know that worldwide, gay and bisexual men and other men who have sex with men and trans women continue to bear the disproportionate burden of HIV in all contexts. But inclusion of these populations in HIV service plans and national policy is often contested, and we've seen a backlash in certain countries. In Tanzania, over the last almost 2 years now, the Ministry of Health has withdrawn condoms and lubricant because they're seen to be promoting homosexuality. So, even when you have a strong evidence base of, what would be preventing new HIV transmissions, there's a resistance. And beyond HIV, there's a real dearth of data on the SRHR status of LGBTI people across low and middle income countries. The commissioners have meaningfully pointed out that there's challenges in aggregating comparable data. But we basically need to reassert a research agenda around this in order to fill gaps. Again, I read out the top 10 services, and a lot of those sounded like basic services. But what do we know about, the experience of an LGBTI person when it comes to those basic things around, particularly when you think about the sort of women's health, family planning, and maternal health care issues that get that much more complex when you can't be forthright with your healthcare provider.
Great. And I know you've touched on this a little bit, but how do we continue to lower those barriers? I mean, if you have kind of a wish list of here are my top 3 things that I've seen in my research and work that are effective at decreasing these barriers, what's on that list?
I mean, I think it all comes down to greater social acceptance. Yes, we want law and policy to change, but even in settings where we've seen a high-level policy change, I did my doctoral thesis work in South Africa that has, the first national constitution to address discrimination based on sexual orientation since 1996, and we're still seeing LGBTI people go into public health care service provision, points of access, and not being able to be treated decently. So I think there's the maintaining our long-standing human rights campaigns to decriminalize and to work more on social acceptance and people, I don't know how much more we can do to help people feel safe to be out to their providers. I think we need to do a lot more to focus on provider training. Medical doctors, nursing staff, even front of house staff, to be able to see people and treat them with dignity and however they present at the front desk and in the clinician's room.
Fantastic. Building on that a bit, Preston, you work with young people, you work with young LGBTQI people. What gaps do you see in this commission report in terms of reaching people in the communities that you work in?
Sure. So Felicity, great point and comment too. I think one thing that we talk about enough when it comes to providers specifically is cultural competency, but not enough about clinical competency. And I think those two have to go hand in hand. You literally cannot talk to or about young people if you don't have the intersection of what it means to be clinically competent and culturally competent. If someone living with HIV comes to your clinic and you automatically want to put on gloves or a face mask because you're not sure, which happens, because you're not sure how to interact with them, you're already, in my opinion, violating someone's access to health and rights and healthcare services. To your direct question, Jill, it's always odd talking about gaps when people who wrote the report are here. So I will say, I say this with love. And obviously constructive criticism in that the report is great, the commission is great, the purpose is great. It definitely sets out on achieving sexual and reproductive health and rights. For me, what it means to acknowledge gaps is to first talk about young people being non-monolithic. The way young people often present or are actually articulated as this kind of one-dimensional young person. This idea that young people have particular healthcare needs, which can be true. But within that, there are gradations of what young people actually need access to. And so I think it's important to specifically call that out and draw attention to the fact that young people are nuanced, multidimensional, full of experiences, needs. They are queer, they are transgender, they are girls, they don't have a gender, they're non-binary. And I think when we actually look at all of those things, because of that, when they're intersectionally linked, they require different needs in healthcare. And so I think that's important to to know. Another thing is when we talk about hard to reach, the one thing I will always talk about at the last International AIDS Conference is a quote that David Malbranch offered, and it was that providers need to stop talking about young people as hard to reach simply because they have not reached them. and right, and it sounds like something that eureka, right? It's that moment, that light bulb moment, but it's true. We talk about marginalized populations like sex workers, like those in rural communities, like intravenous drug users, like people living with HIV. We talk about all of them like they're so hard to reach just because we have not developed the tools and skill set to be able to reach them. And so I think that's another portion that I would really note. The last two are words that in DC I've been hearing a lot lately because of who our leader is. Air quotes, who our leader is. What I'll also note for Advocates for Youth is that one of the major gaps that I noticed in reading most of the reports when it comes to sexual and reproductive health and rights is the lack of acknowledgement of white supremacy, colonialism, and imperialism, and the direct link that has to who has the ability to have healthcare access. If, for example, the United States offers or suddenly defunds, places, and because of things like, I don't know, the global gag rule or UNFPA, then that means that people will not have access to particular healthcare services like abortion, because abortion is a healthcare service and it's a medical procedure. And so that being said, I think we have to talk about the link that white supremacy, colonialism, and imperialism has on who has the ability or non-ability to access healthcare, and young people are a part of that. And what I'll leave off with, because I think I'm over my 2 minutes, I'm sorry, Jill, is reproductive justice. So though we realize that sexual and reproductive health relies on the rights, neither rely on anything without reproductive justice. And so because we acknowledge that, and because we know that it's the commission is comprised of experts around the world, it makes clear of what we need for SRHR for all, it means nothing if we aren't acknowledging the movement that's been happening, what happened in Cairo, what's happening with ICPD, what happened in America when Black women and brown women and those who are marginalized created what we know as intersectionality and created what we know as reproductive justice, which is the acknowledgement that folks walk into a space fully nuanced, fully intersectional with all of their identities and not stripping any of their silos simply to make a provider happy or more comfortable. And so the things, again, I would acknowledge and leave off with is reproductive justice understanding, specifically calling out systematic oppression, white supremacy, and imperialism, and acknowledging that young people are not monolithic.
And I mean, to follow up on that, you've identified many of the gaps in the report, which I think we all find quite helpful as much as we love the report. I wonder, do you have sort of a specific story or an anecdote that can give us sort of an illustration of what can happen when young people are in the driver's seat for policy, that can also illustrate perhaps how some of these gaps could potentially be filled?
Sure. I'll give an example of, I guess even like service delivery or services. So in our work in Burkina Faso, we made sure young people were involved in a community mobilization with the healthcare center. And the healthcare center, frankly, did not want to take any steps in what the young people said. To be honest, it was a turf war. Some providers thought young people should have kind of just sat down and really not allowed them to do their job, while young people were really advocating for themselves for things like a curtain to be put up when they're changing clothes or when a procedure is occurring. And so what really happened, frankly, was that based on young people and young people's recommendations solely, they were able to get things like a curtain placed up, having games in the waiting room when they were in there for about 7 hours, right? Like simple, what I would consider things that I would hope would be at the forefront of someone's mind, but may not be. And so something like games in waiting rooms. There was a staff person finally hired as the go-to person for adolescent-friendly services. They just kind of assumed that everyone was clinically and culturally competent, and young people were like, I have a surprise. No. And because of that, surprise, they finally hired someone, right? And I think that, that seems like small things, but those small things make a really big difference. And when people can do things like disclose to their healthcare providers, frankly, I know that we have these conversations sometimes about coming out or inviting in, as I would prefer to call it, to your healthcare providers. Frankly, people don't invite their healthcare providers in because their healthcare providers are discriminatory, or because they know their healthcare providers will suddenly be surprised and not honor, basically what they're saying and how to have access to their own body, or not honoring their bodily autonomy and integrity, So that's probably the best example. Another example from a policy perspective is actually work of our young people, specifically one, Caitlin Caruso, who I'll call out. She did a lot of work in Nevada. And Nevada it's funny, I mentioned Nevada because people from Nevada want you to say Nevada. So thank you, Caitlin, for that. And so with the work in Nevada that Caitlin did, I think they didn't update their statute on sex ed since like the 80s, which is sadly probably better than many other statutes in the country on sex ed. But they didn't update it since the 80s. And so they were making sure that it was more inclusive. And so though they didn't get their final LGBTQ inclusive sex ed bill, they did take it to the Clark County School District, which is the third largest school district in the country, and then they passed an LGBTQ inclusive sex ed provision because of young people's work. And so I think you'll see or understand when you put young people in the driver's seat, young people will let you know if they actually know how to change and advocate and push for progressive policies and provisions and practices.
Thank you. And I just want to briefly, for folks in the audience and watching at home, I know I don't work in this space, and so sometimes some of the lingo or the words can be unfamiliar. So if some of the concepts that Preston just raised, like intersectionality, if that's new, it's from a great law review article by Kimberly Crenshaw, and you can Google it and find it at home. Ditto reproductive justice. If you go to sistersong.net, they have a whole section on what reproductive justice is and the history. So if those were new concepts to you, I would really encourage you to do a little bit of research on your own to read up on them, because they're really, really crucial, and I'm glad that Preston raised them.
And if I may, there's a reception that I would love to talk about intersectionality over wine, so yes.
And Patricia, you are our UN liaison, an organization that plays an enormous role in setting global normative frameworks on human rights, including gender equality. What trends are you seeing in that space on sexual and reproductive health and rights?
Thank you, Jill. Actually, before I get into that, I just wanted to clarify something real quick that Preston just said. So UNFPA does not provide abortions. Mm-hmm. Okay, let's just make that clear. They do not provide abortions. Exactly. Actually, no UN agency, none of them, has a mandate to provide abortions, and that's really important. Just want to make sure not to let that lie there. In terms of trends, so what I would say is that ICPD really gave us a scientific and evidence-based baseline on the principles for SRHR. Those are really the principles that we have been worked on for about 25 years. They have, of course, meanwhile evolved. We have reviews every 5 years. The latest, I think, that we have is the ICPD Beyond 2014. But we have also implemented other SRHR related service. We had the MDGs, and now we have the 2030 agenda, which of course also includes a lot of those SRHR components that are coming from all those other spaces, Beijing, CPD, et cetera, et cetera. The good news is that there is a broad realizations from countries to support these agendas. They have, particularly developing regions, they have made a lot of progress, and they have come a long way in really making progress in achieving some of those health goals, particular section of health and health goals that are fed through the planning of those agreements. So we have made progress on maternal health care. We have made progress on HIV prevention. And many other areas. And so even countries that tend to be conservative and that may or may not have issues with certain parts of the agenda, overall will embrace the agenda as part of their development portfolio to move their agenda forward. But unfortunately, we are not quite there yet. Like I mentioned before, it's 193 countries, so making
finding consensus and finding agreement, it's really hard. And usually really what happens is that we end up in a middle ground, which it is kind of what makes sense in a multilateral space. So for example, we still struggle a lot, just to echo the colleagues here, to agree on any language that is related to LGBTQI peoples, particularly in relation to access to services. We still have an extremely hard time talking about youth, particularly young girls, and particularly if we want to talk about their right to bodily autonomy. There is a lot of misconceptions of what is a girl with bodily autonomy, and the misinformation will say things like, oh, they'll just make them their sexual debut much earlier because they're having these conversations, or they're just gonna go out and start drinking and meeting boys, or smoking, or, if you talk about comprehensive sexuality education, which is, we have an amazing new guidance from the UN, but again, there's still a lot of misconceptions there. Oh no, little boys they're gonna stop masturbating at 3 because they haven't. I swear, I know. I mean, it really is it gets quite absurd. And so while a lot of the people that we talk with, it is very sophisticated and they understand that this is misinformation, we still find it difficult to make progress on some of those issues. But I think one of the most concerning trends that we're seeing right now is this idea that we need to narrow the scope of sexual and reproductive health. And that is extremely dangerous. It is extremely dangerous because there is a reason why we have just now in the report, we have a definition that it's quite broad. And there's a reason why we want it broad. It's because all of these concepts are part of it. But then in a global space like UN, each country then has, in their own national capacity, has the ability to look at their country and understand what are their concerns, what are our priorities, what is the picture of our health in epidemiology, and then make priorities based on that. And they pick what are the issues that they should push forward the fastest, or that they should invest more on. It is not the global space that is making those choices. The danger of a space like the UN trying to narrow the scope of SRHR is that we're going to miss a lot. I mean, men and boys need sexual and reproductive health too. And so if I'm writing a resolution and a handful of countries is insisting that no, we cannot have SRH, we want maternal health, I'm like, we can't have maternal health. Because besides all the other services that will be out of that very specific health need, we also are leaving out many other types of people, women that are not mothers, for example, or men and boys. And so there is a reason why we choose to use these broad concepts, is to ensure that we are inclusive. And so countries that have made progress thus far with ICPD, with Beijing, with the MDGs, they understand. They're like, oh no, we're going to keep doing this because it works. We know the development that we have made so far, and we are not in the business of going back and try to renegotiate what this means, something that we negotiated 25 years ago. It does not make sense. It does not make sense in a practical way, and it does not make sense in a development way either. So I think in terms of trends, those would be the most concerning ones that we're seeing. But the good news is, like I was saying, it is, particularly in New York, you have a cadre of diplomats from all the regions that are very sophisticated, very well informed, that they understand development, they understand rights. And so those, every once in a while, there are a little bit of scare tactics of misinformation. They're past that. They're making decisions based in facts, based in evidence, based in what they have witnessed. And they are making decisions that are helpful and they are positive for their development and their rights agenda.
Fantastic. Thank you. Mabel, you told us about the sort of process in Argentina over the past couple decades to get to the point that we got to last year, where legal abortion was so close. Can you tell us a little bit about kind of what lessons we should draw, not just for Argentina, but for the region more generally, from the Argentina case study? What worked in pressing for safe and legal abortion? What didn't work? What could be done better next time?
Well, first of all, I think it's very important the persistence, because these things takes a lot of time. So you couldn't think we are going to pass it in 1-2 years. You need to persist. And it's very important to develop alliances. And some of the alliances I think we have been doing well in our region is the alliance with the journalists. So journalists help us a lot, not only in Argentina, in the region. And also they create networks of journalists pro-sexual and reproductive health and pro-abortion including. So this is very important. The other is to have alliances with the medical associations, specifically those working gynecologists, sexual and reproductive health, adolescents, young people. So those are the groups. Lawyers associations also is important. And finally, I must say we need to have the mobilization of the people in the streets. That's why it's so important, the young people, because they are strong, they went there, they are present there. So this is something I think we have been doing a lot in Latin America, and this was something good. What is something that is not so helpful, let's say, not so good? First of all, as I said before, it's important that we make our presentation not based only in the rights of the women or the young women. It's necessary to press based on the health risk, the mortality risk, the bad things that the people understand and are very clear. And that was so good, the association with feminicides and violence against women. So this is very clear also, and it's better than if we stress only the rights of the women. That seems to be is only some individual and not so much with the social activities. The other issue, I think, is we didn't strengthen still so much in our region the participation of the feminist women in the political parties. We need to strengthen that. Why? Well, because there is going to be where we need to fight, okay? So we need to be there. If we are not there, no one is going to be there. So we need to have, many years ago in Latin America, we discussed about if it's good that the women, the feminists, we enter the UN, the United Nations, or we enter this organization, international organization, foundations, and so on. But we never discuss about the issue of political parties, and we need to be there. And this is something that is important, and I hope we understand now.
On the issue of political parties, we've seen around the world a rise in right-wing governments, and Brazil has the sort of latest strongman who's recently been elected. What do feminist abortion rights activists have to look forward to in the region, kind of given Bolsonaro's rise? And how can we both kind of push back on the regressive policies that I think many of us suspect are coming down the pipeline, while also kind of keeping an eye on what the big picture goal is and trying to move forward?
Well, the issue of Brazil is a very good issue. Why? Is supporting what I said about the need to work in the political parties. Because what happened in Brazil is happening in all the countries in the region, and we are not taking care of that. That is the new evangelical groups coming and increasing due to the poverty. They are working hard with the more poor people, and they incorporate in the political parties, and they are in the parliaments. So we need to be able to run with them and be in the political parties, not only having the support for the ideas, but also to be in the parliament discussing, because this is the way where they work, and they try to push back all our issues. The second is the issue, well, these are it's very difficult. When I've been the last days in Rio de Janeiro, and it's so impressive how the reaction of the people with this, the new women in charge of Women Affairs Ministry. So it's completely now to say that the princess and the prince, or the color of the dresses, the blue and the rose, this is completely now impossible. So the people, how they react, and they react, many people that they are not feminists, they are not very special working on those issues of sexual and reproductive, but it's logic. It's something that now is very difficult. But meanwhile, we need to be there because they have the votes. And with the votes, they do things. And this is the problem. And they allow, and also I think it's very important that you realize how was the support from this group, economical support from this country to the groups there. So we are suffering without money, our activists, and they are having plenty of money. And what they are telling now, and the movement, how it's moving, against feminism, against gender, and against the right of comprehensive sexuality education in schools. They are mobilizing in all our countries in the region, saying that we couldn't make comprehensive sexuality education because it's the right of the parents that do that. So we need to avoid. So we say, well, don't send the children to the schools because the schools need to teach everything. So this is something that you need to realize because this country is very important in our region. And it's not only important due to the importance of your country, but due to the money they are investing and the issue that how they are impacting, and also how they are giving money to the political parties to incorporate and to follow them. So you need to realize that. So sorry to say, when you vote here, you are voting for our countries. Sorry, you need to think better your votes.
Thank you. If folks in the audience have questions, you can go ahead and raise your hand. I think we have people with mics coming, or we don't. Maybe you'll stand up and talk loudly. Great. If you could please keep each question to a single sentence, make it actually a question and something you actually want the answer to. I'll take all, I guess we'll just take all four of them, and then each panelist will choose which one to answer. All right, so we can start, I think, passing the mics down.
Hi, this will be a run-on sentence. I had the opportunity to work evaluating the Ford Foundation's signature program, which was Global Dialogues on Sexual Health and Well-Being. That was a 20-year project. I'm happy to talk about that. My question is this. The population is aging, and I'm wondering if the report at all talked about the issues and the challenges of sexuality for older folks, men and women. We're here, we're not going away, and there are stereotypes, and it's certainly an area that needs some guidance and some support.
Fantastic. Can I just ask you to introduce yourself briefly?
I'm Dr. Mindy Reiser.
Thank you. And then to any of the three folks over here, we'll get all of you.
Hi, I'm Kate Gillis, and my question is about the power of religion and faith and the influence that has over people's beliefs and attitudes and social norms, and how we can harness religious leaders as supporters for progressive SRHR instead of just sometimes obstacles.
Thank you.
Hi, I'm Jill Gay with Works Association. My question is, even in countries where abortion is legal, like Nepal, adolescents it's very hard for adolescents to access. They need parental or guardian permission? And how do we work on those issues? Ethiopia is the big exception.
And you can go ahead, sir.
Oh. Do I need to stand?
You can do whatever you want. Yeah, you're good.
Name's David Onspach, retired member of public and celibate asexual. My question is, I hate homophobia, sexism, patriarchy as much as anybody else in this room, but I also hate the cost of careless pregnancies. My question is, do you support it being a right for someone who's been convicted of felony child abuse and neglect, or somebody who owes legally required child support, or somebody who's getting aid, welfare aid for themselves and any children they have, to conceive additional voluntary pregnancies, even if that means more children being abused, neglected, abandoned, and more costs on society to take care of that? And number two is, do you support someone who has been diagnosed with HIV or other sexually transmitted disease to be allowed to have sexual relations with another person without telling them they have the disease, even if it means that person also gets the disease? Thank you. Do you support those being rights? Thank you.
So I'll let each of our panelists decide which of those questions you want to address. Again, we only have, unfortunately, a few minutes. I'm going to throw one more out there, if you don't mind, which is, what's the role of pleasure in these discussions?
Everything.
We talk a lot about sort of the negative outcomes, and Felicity touched on pleasure, and Mabel also touched on the sort of reality on the ground in Argentina, which is really highlighting the downside of outlawing abortion. How do we reframe LGBTQI rights, being trans, as a pleasurable and positive experience, as sex as pleasurable and positive, as access to abortion as a component part of a normal, healthy, positive sexuality? So I know those are 5 questions. We've got pleasure. We have a question about HIV status non-disclosure and a right to pregnancy. We have questions about adolescent access to abortion, the role of religious communities as leaders in sexual and reproductive health and rights, and sexuality and sexual and reproductive health and rights for older folks. Is there anyone that wants to grab one of those and start? Yeah, Patricia.
I can comment just real quick on a couple of them. So regarding the aging, you'll be happy to know that there is a whole section on aging, which I was also very excited about, as I'm quickly getting there. So yes, I think it's very important, and I've just had this conversation about our community really engaging the aging community more on issues related to sexual preferences and reproductive rights, because I think they would bring a different frame that it's important that is part of this conversation, and would inform also not only our advocacy, but also our work and the design of our programs that would be inclusive to people of age. So yes, it is there. I want also to quickly respond to the person that asked about the religious and faith organizations. It is actually this year, it is on my to-do list. It's one of my main goals is to engage more meaningful with faith organizations and religious groups. I think it's really important. For example, on comprehensive sexuality education, some of the most successful programs are the ones that we have are those where we took the time in communities to really involve the local religious leaders and getting their input on how the programs should be designed, how should they be implemented. That was in addition to parents and other community leaders. So I think that is really important and really can take us to the next level in terms of particularly on the ground and how we interact with communities. I had one more answer, but I can't remember what it was, so I'll let someone else go.
Mabel, was there one question that you wanted to address?
Well, I want to come back to the issue of pleasure because I think it's very important. And I think this is the base for the comprehensive sexuality education. And I say that because, in general, when we talk about sexuality, we talk about gender, sexual relations, and we are not talking about pleasure. And our young people is having a lot of sex, but they are not having pleasure. And this is terrible.
Oh, say
This
that
is terrible.
Yes.
This is. So we need to teach them how to have sexual relations with pleasure. If not, this is nothing. This is only something biological, but nothing else. So I'm an old sexologist, may say, in which I believe some old traditions working with the people, teaching how to be more able to have pleasure, and how we need as women, what they need as men, how we put together, and how this happens. And this is something that I think we need to come back. And this is also related to the elderly. I must say that I'm very interested because I'm an elderly woman, and I have the right to have pleasure and sexual pleasure. And this is something that we need. So it's very important to work with the young people and put together adolescents with their grandparents in order to speak about that. Because, both of them have something to say.
Yes. Yes.
The grandparents can learn something or teach something to the adolescents about how was pleasure in their time when the life is not so open to have sexual relations. And the young and the adolescents could understand better than the adults the rights of the elderly to continue having sexual pleasure and sexual activities. So this is something that's why we need to strengthen. And I'm very happy that it's something in the notes. I didn't read really about that, but I think it's very interesting. But that's why I say comprehensive sexuality education is much more than to speak about sexual relations. It's about the cultural values, how we understand life and sexual life. All of us have sexuality since we born till we die. But it's different, we have different issues, so it's something to work and to make pleasure to the people and to find good pleasure, not only eating or doing something else.
Although
Thank
eating
you.
is good.
Yeah, eating's a great pleasure too. I'm not against that. Preston, did you want to take?
Oh, okay. Sorry. Speaking of pleasure, I didn't know. So, Jill, I would love to discuss your answer later. So please flag me down. I have to take this public opportunity because I would be negligent to not address the last question. So I think it's very important to be mindful with language when we discuss things like racism, sexism, misogyny, etc. We can't be all of those things, but we have to be all of those things and so I think it's really important first to start out with that. Secondly, I think the notion of, so let me just flat out say, yes, everyone of reproductive capacity is entitled to an abortion. Everyone is entitled to sex. Everyone can have sex, consensual sex, that period. And also to that, I think, I'm speaking of the United States context specifically, though I think it applies in other areas. There's a notion of who is and who is not entitled to abortion, be it young people, lesbians, trans men, etc. There's also a notion that Black women are not entitled to abortions for a variety of reasons, right? Or even be pregnant, right? Which is why we could talk about the laws of sterilization and the laws of shackling throughout many prisons throughout the country. And so the idea of a welfare queen or someone who can't take care of their children is historical fallacy. It is rooted in racism and sexism, and it's something that applies heavily to Black and Latinx women. And so I think it's really critical to have a conversation around what it means for folks who, if someone asks a question, for example, here the last question about who is not, or should everyone be entitled to an abortion, even if X, the answer will always be yes for me. So I want to say that is one. The second part of the question is more so about HIV criminalization and sexual pleasure in sex. Everyone needs to protect their own bodies. The problem is when we have conversations around people living with HIV and other STIs, the idea is that the onus is always on them to disclose. from my view, the onus is on all of us to ensure, if we're protected, quote unquote, that everyone must protect their own selves. If that means pre-exposure prophylaxis, if that means condom usage, that means that we have to take ownership over our own bodies. It is not incumbent upon people living with HIV to continuously disclose. What I will say connected to that is the idea of prosecution for living with HIV. Everyone in the room should really check out the Center for HIV Law and Policy and the work that they've done in ensuring that HIV is continuously decriminalized across the United States. Because when we talk about who's living with HIV and if people living with HIV are no longer suddenly entitled to have sex because they are living with HIV, and then we connect that to who's actually being prosecuted for living with HIV of alleged non-disclosure, what we're really discussing are Black gay men and Black trans women. The quickest examples we can think of that is Michael Brown in Missouri, who the media by and large called Tiger Mandingo, which, surprise, he's Black, he's gay. And the language of Tiger Mandingo, even though that was his wrestling nickname, was also continuously used by a lot of media in a very salacious and negative way. I can talk about this for a while, but I do think that it's important that we acknowledge that HIV criminalization laws are heavily rooted in homophobia, transphobia, biphobia, and interlocking links that we have with the legal system that is heavily racist and sexist. And I think it's also important to note that every single person of reproductive capacity is entitled to abortions, regardless if we think that they can't take care of their child. If someone wants an abortion, the answer to that is have an abortion if you choose to do so. Period. No exceptions.
Thank you.
Jill, I just...
Yeah, please.
Very well said. And I just want to add to that. When we talk about reproductive rights, we're not just talking about the right of women to have an abortion if they so choose to, but also the right of women to have a child if she chooses to have it. And so it is comprehensive. A right that is comprehensive and it's holistic. You cannot stop a woman from having a child if she has made that choice. Mm-hmm. So I suppose the answer to that question would be yes, she can have her baby or as many babies as she wants. And the trick here is that if she's having some other kinds of social issues, then we will try and find out the underlying causes of the situation that she's living and put her in those programs that can help her address those issues, not stopping them or her from having a child or that she wants to have.
Thanks, Patricia. And again, I'll really recommend the website sistersong.net. They're the ones that so Women of Color Collective, they came up with this concept of reproductive justice, which encompasses not just the right to end a pregnancy or prevent a pregnancy, but also the right to raise a child in a safe, nurturing, and supported environment, which is really crucial to a lot of what we're talking about here. So I know these questions around who has a right to have babies, they come up. They come up in policy, they come up in discussions. And I think for myself, they can be sort of triggering and upsetting to hear, to be honest. I know that one was not meant maliciously, but I would really encourage folks that are watching at home or in the audience to do a bit of research yourself. And, there are great resources on this, and I'm really grateful to the panelists for addressing that. Felicity, I want to end with you. Were there any of these questions that really stood out that you would like to address to end on?
Yeah, the whole question of how to leverage faith leaders is something that I think I'm really pleased to hear that's on the radar for IPPF and others. We have a very strong sort of coordinated group called the Global Interfaith Network that works on people of all sexual orientation, gender identity, expression, and sex characteristics. And it's a welcoming, inclusive umbrella that's trying to help LGBTI people live in their spiritual lives and thrive in their spiritual lives across a multi-faith landscape. Turning them into advocates for better sexual and reproductive health, I don't think is a big ask because that network is really a sort of legacy of faith leadership in the AIDS response, particularly in Southern Africa. So I think there's some connections there, and it really goes right into this sort of issue around why have we not been prioritizing sexual pleasure over the last several decades. And I think, we've had sort of pre the HIV response, we've been trying to, have some magic bullets that fix problems around fertility and maternal mortality and the whole agenda, and seeing, female sexuality as something to control and coming up with technical solutions to fix. And then in the AIDS response, we've also had that, but we've had good funding pouring into the HIV response that I think you could find, a whole generation of gay and bi men and men who have sex with men who've actually had better sex because they've had safer sex. And that's been really encouraging, but you haven't seen all people of all sexual orientation, sexual and gender minorities benefiting from that kind of programming. And I know that when I was working closely with lesbian and bi women in South Africa, there's so much of a focus on, victims of corrective rape, that they weren't being able to talk about healthy and pleasurable sex lives and relationships, and all the ways that they could support one another as friends and partners. And I think that's something that having this meaningfully framed in the Commission report, that sexual pleasure is a human right. We need to start encouraging funders to be thinking about ways to bolt on to the existing packages of the kind of public health responses that we've been seeing in the response to HIV, to be thinking more holistically about other community members that we could reach to make smarter sexual decisions, safer sexual decisions, and more pleasurable ways to stay sexually active. I'll leave that there.
Fantastic.
I know. Just 1 second. I just forgot.
Please, have the last word.
Just one last thing that I forgot to say earlier. There are several big negotiations that are coming up, global big negotiations that are coming up. And for the SRHR community, it's really important that we watch those spaces. I'm talking about migration just ended, but there will be other components of it. I'm talking about universal health coverage. I'm talking about refugees. Our issues intersect with them, and sometimes are affected in quite a negative way. So while it's not an obvious place for us to be, but we do need to be there, because we want to make sure that our issues are addressed in a positive manner in those spaces, and that we get something positive out of those negotiations. So just to put it as a pin for everyone to keep in the back of their minds.
Thank you. So I just want to end on a note of gratitude for all of you for being here, to the Wilson Center for hosting, to the Guttmacher-Lancet Commission for putting together something so phenomenal, to our wonderful panelists who will all be around during the reception if you have further questions, and also to the folks who did the invisible labor that made today happen, who brought in the chairs, who are going to help set up for the reception, who put up these microphones, who are doing the video equipment. These are all really crucial component parts to everything that all of us do. So thanks to all of you, and we will see you at the reception.